So with that, I want to invite our next very important panel to the stage. This is obviously a staple for the National HBPA and our medication committee. For years, started by Kent Stirling, the conference has somewhat ended with the medication panel, where there's been a variety of topics through the years. And this year is no different, and it seems like every year we get more and more into the weeds, which is a good thing, but we also get more and more relevant, and we start to see positive changes from our perspective, from a horseman's perspective, and we continue to try to do such now that we have this new regulatory authority. While we're dealing with them, we're going to continue our push, our message, in the hopes of being able to get medication and the thresholds and standards used that are based on science, specifically equine sports medicine, veterinary science, and peer-reviewed research. That's what's important. That's not what's always done. So with that, I want to give a special shout out to our sponsor for this panel. Ohio HBPA has always been very supportive of National HBPA, President Joe Poole, obviously the Executive Director, Dave Basler, who is the committee chair for the Medication Committee and the Model Rules Committee, always instrumental in our representation on the national level between the RMTC and the ARCI. So let me introduce the panel, and I guess they're going to parade up here. So we first have an introduction to Dr. Tom Tobin. Hopefully, well, it does not look like he got his mic on. So, okay, it's on the floor. I put it down there where it was easy to get. So we're going to go to our seats. All right. So Dr. Tom Tobin, while he gets mic'd up, stop right there. Stop right there. Stop right there. We'll get you mic'd up here. I don't think anyone needs to have any introduction spelled out for you. I would say that maybe an eighth of his bio is in the book. We have to edit the 17 pages to make it basically 3/4 of a page. But Dr. Tobin, world-renowned research expert, toxicology, pharmacology at the Gluck Equine Center. In addition to Dr. Tobin, we're honored to have Dr. Clara Finger, again, a world-renowned expert, widely used expert witnesses in a number of cases dealing with tests and violations through the years, even now under the High Woo arbitration, still utilized as an expert witness for horsemen. Next, we're very happy to have, I believe for the first time, I don't want to be misquoted, but I believe for the first time, Dr. Rob Holland. Dr. Holland is, as I say, a man of many hats. I'm proud to say that he's been a good friend of mine and my wife, Deborah, for quite a long time. He worked alongside my wife at Zoetis years ago. But Doc is kind of known around Lexington as the man that can heal your horse. He works for a lot of clients, specializing again in equine diseases and more specifically biosecurity. So at the end of the day, if you've got a problem, many people call Dr. Holland. But now he is, and I think to our favor, he has been appointed to the HISA Furosemide Advisory Committee. Still hard for me to say furosemide, not Lasix. But he is now on that committee, the committee that was established in the Act, as most of you know, to review and or I guess evaluate research being done and funded by HISA to establish the need, or in their words, not the need for Lasix going forward. So We believe a sound mind is at the table, and we're very appreciative of that. And certainly last but not least, we've invited trainer Ron Moquette, Breeders' Cup winning trainer, obviously extremely successful, but also a voice for the HBPA. He is an Arkansas HBPA board member. He's been very vocal about issues and the problems that we've had under HISA and HIWU, but he's also there to be a sound mind and reason for finding solutions. So Ron is on the Horsemen's Advisory Group that was established, I would like to say, because of the constant pushback early on from horsemen such as the National HBPA, that they needed to have voices such as ours at the table. Too bad they didn't do it when we got started, but at least now Ron, along with our Dr. Doug Daniels, chairman, president, is also on the Horsemen's Advisory Group. So with that, I'm going to turn it over to Dr. Finger to start this wonderful medication panel. Thank you very much, guys.
Thank you, Eric. So well, our focus today was the establishment of no effect thresholds. This was, it was a charge we were given actually by Eric, so by the National HBPA. I will tell you that the United States Trotting Association is involved in this process as well. So the history of drug testing in horse racing in the early 1900s, some Russian regulators walked into the paddock in a Russian horse race and took horse saliva from the horse of trainer John Keene. That's John Keene of Keeneland fame, and administered the saliva to frogs because they were tired of getting their asses whipped by this American trainer. The frogs began to behave in a very unfrog-like manner, and John Keene was expelled from racing in Russia. So just as an example, that's the first known incidence of drug testing in horse racing. We're just going to fast forward to today. In the 80s, and just to make sure that credit is given where credit is due, the advent really and truly of modern drug testing was actually brought into place by the HBPA sponsored the HBPA is the original group that brought Dr. Tobin into the Gluck Center. And he started a novel technique of the introduction of ELISA testing, which got our testing into really relevant ranges. So nanogram per mil to picogram per mil. Now we're going to fast forward to the 2000s, where instrumental mass spectrometer screening is done. So prior to the 2000s, if you happen to have intel on which drug they were testing for this week, cheating would be kind of easy if you could figure that out, because they did rotational testing. They didn't test for everything all the time. Mass spec changed that, and obviously it changed it for the better, because LCMS permits the simultaneous identification of hundreds to thousands of drugs at very, very low concentrations. So the question was never asked at that point, what concentrations matter? And so here we are. Why do we need no effect thresholds? Because as Andrew Cohen pointed out in a recent TDN article, any justice system, including a system that regulates horse racing, should strive to have punishment fit the crime. When it comes to contamination positives, especially unintentional ones, federal racing regulators still have some work to do. At this point, contamination positives are treated identically to if you had administered a full pharmacologic dose on the morning of the race. So if you were to test positive for heroin, which would be morphine because it's metabolized, but you at a trace level, that the penalty that you would get in the current system is exactly the same as if you had administered a full pharmacological dose race morning. So there needs to be a differentiation. So in humans, in WADA, there's 0.77% positive tests. That's in 2022, the last time they published their findings. In US horse racing, going to the HiWoo 2023 report, they had 0.49%. So that's actually not a lot different than what was found the previous year under the state regulations. Most of the adverse analytical findings by the World Anti-Doping Association are actually performance-enhancing substances. They only test in urine for certain substances that are, serious performance enhancers, such as growth hormone, anabolic steroids. And in fact, the majority of their positive tests, realizing that the majority of positive tests in horse racing are for things that are not even tested for. So the obvious one would be metformin. The majority of adverse analytical findings by HiWoo are overages of therapeutic medications or levels consistent with environmental contamination. Don't know the details of the facts of every case on the HiWoo website, but certainly the substances, even the ones that are somewhat rare, meaning a single finding like lamotrigine, are substances that our research group has identified as being highly stable in the environment and highly prevalent because of the number of humans that are on the substance. So the first question is, what does the Act, the Horse Racing Integrity and Safety Act, actually say about drug testing? Well, they say covered horses should compete only when they are free from the influence of medications, other foreign substances, and methods that affect their performance. Again, the influence of medications. And then they also say that if they're injured or unsound, the use of anything that is going to block or deaden the pain, that shouldn't be allowed either. I think we're all in agreement with what is actually in the Act. But unfortunately, the current system of calling positives at the limit of detection actually fails to comply with the Act. The argument, among the arguments that we've heard from the Heiser Group, is that certain substances have no business being in a racehorse at any level. And the insanity is, because we know a lot about contamination, contamination has been a focus of research across the globe since the year 2000, as the LCMS has come into play. Contamination happens, and these levels mean nothing. And most importantly, they don't influence horses. And then right as we were coming here, Dr. Tobin sends me this article. So they actually found cocaine and the primary metabolite. This is an article from July 15th in 2024. So it just came out. They found traces of cocaine and its primary metabolite, benzoylecgonine, in sharks off the coast of Florida. So obviously, there are a lot of substances that have no business at any level. But that doesn't matter. It happens, and it shouldn't be penalized, and we should be able to identify a level at which these things have no effect. So, environmental substances, positive tests from transfer to horses of trace amounts of urine in stalls, on hay, residual substances on hands, weeds present in the hay, even in the water, at levels that are unlikely to influence, again, their words, not mine, a horse on race day, are destroying the reputation of the horse racing industry. It is critical that as an industry, we address this problem in a manner that preserves integrity of the racing product. Emphasis back on influence. Safeguards the health and welfare. Influence. Also prevents penalizing both owners and trainers. Right now, the owner is penalized in every case for positive tests that are likely to have occurred as a result of environmental transfer. So if you thought that that was too sciencey, now we're going to get into a little bit of the science. There are two general categories of types of drugs when it comes to drug testing. Drugs whose effects are driven by blood concentration, meaning You see it in the blood at this level, it has an effect. So you have to have a level in the blood in order to have an effect. And the second group is drugs whose effects are separated from the blood concentration by time or space. So I'm going to start with the drugs whose effects are driven by blood concentration. This is a dose response curve. So sorry about the signs. On the x-axis, so the horizontal axis, is the dose or the amount in the horse. So you can think on the far left, we're thinking picograms, okay? Far left, picograms. On the y-axis or the vertical axis, we're looking at the response. So what happens in the animal, what you see. So as you can see at the far left of that sigmoidal S-shaped curve, the dose is low. Again, think in picograms. The response is 0. These substances exert their effect by occupying receptors on cells. So you've got drugs running around, you've got receptors. So if there's no receptor, it has no effect. It has no effect at all because the cell can't respond. So the actual drugs have to bind to receptors. So it takes a minimum number of receptors. And just as an example, there are, on any given cell in the body, there's 10,000 corticosteroid receptors. So corticosteroids are dexamethasone, betamethasone, depomedrol, triamcinolone, corticosteroids. So in any given cell, there's 10,000 receptors, and about half of those receptors have to be bound before the cell starts to make a response. So as you can see, now I've labeled your sigmoidal curve, picogram concentrations. So you can have 1 picogram, no effect, 2 picograms, no effect. There's no receptor binding at all at those very low levels. Even as the curve starts to turn upwards, where you have a response, there's no measurable effect. So all of the other things going on in the animal are more important to the animal than that tiny little response that you get. Usually takes about 50% of the receptors to be bound for you to have a reaction or have a measurable response. And obviously at the top end of the curve, you have maximal dose, maximal drug concentration, and response is maximal as well. So you can actually, with these drugs, you can determine what's called an irrelevant plasma concentration. This is a procedure that was suggested or proposed by French pharmacologist Pierre Toutaine, who incidentally is instrumental in setting the European drug thresholds. And so what they have done is they determine what the effective plasma concentration is, which is usually gleaned from the literature rather than actually performing an administration study. And you can conduct these or calculate these no effect thresholds quite readily for most of the drugs in this this category, drugs whose effects are driven by blood concentration. So what are those things? It's almost everything that we test, almost. So flunixin-banamine, phenylbutazone, metformin, methamphetamine, drugs whose effects are driven by blood concentration. And European medication control relies heavily on this Toutaine method, where irrelevant plasma concentrations are calculated from effective plasma concentration, with the highest level that we know of for Europe being about 1/20th of the effective plasma concentration. Usually they use a smaller fraction, 1/50th, 1/100th, 1/500th. So the second general category are substances that exert their effect separated in either time or space. So you can't use that simple no effect threshold, irrelevant plasma concentration calculation to come up with that. So examples are lidocaine, carbocaine, local anesthetics. I block the foot to see if the horse is lame in the foot, but I'm determining medication control by blood, which is not very close to the foot. So that's an example of a drug separated in space. A drug separated in time, an example is erythropoietin. And that is the effect is observed well after the drug is no longer in the body. So no, we're going to go by, we're going to start with the group that is effects separated from the blood concentration by space or distance. No effect thresholds for drugs separated from their blood level in space can be determined using a no effect dose testing. And this was originally proposed by, again, our own Tom Tobin, again, research sponsored by the HBPA. So what they did in these studies, they did a bunch of the local anesthetics where they blocked their foot and then tested their blood to determine at what concentration where the drug had no effect, again, no effect thresholds, no effect on blocking the foot, what was the blood concentration? And so he has developed a number of those for lidocaine, carbocaine, and we have continued that research. Now, no effect thresholds for drugs like EPO that are separated from blood concentration. It's difficult to establish simply because they're already gone by the time you have an effect. This category includes anabolic steroids, selective androgen receptor modulators, which are not anabolic steroids but work on the same receptors, erythropoietin, and some others. But luckily, these things represent a very low risk of contamination, and they're best controlled through other means. So out of competition testing, biological passport technology. And again, these are things that are currently being looked at by your own HBPA sponsored research group. So you can't really establish a threshold for those things. So we're not going to talk about those anymore. So there's 3 methods that we can use to fulfill this initiative. And that is the 3 methods to determine no effect thresholds. The first one is very simple and probably applies to almost everything because the vast majority of substances that we look at, and that is the calculation of the irrelevant plasma concentration or no effect threshold using the Tutane method. The second group is, as Tobin conducted with the no effect thresholds, it's doing experimental studies or combinations of the above. So just to introduce your research group includes me, Dr. Tobin, Dr. Holland has recently joined us, Dr. Kimberly Brewer has been part of the team since before I've been part of the team. Andreas Lehner has recently joined the team, and others. So we have a stout scientific team. The criteria that we need to set are the levels identified. This is the #1 criteria, right? Low probability of influencing the horse at the time of the race. Levels identified must be inconsistent with a race day administration. So let's just look at SGF 1000, which they never could prove did anything, but you still oughtn't be giving it on race day. So levels identified must be inconsistent with race day administration. The studies conducted, this might be the most important thing, they must be scientifically valid, meaning published in peer-reviewed journals. What that means is that our study is sent out to scientists by the editor of the journal that are familiar with this field of study, and they look at our study design and our conclusions, and they say that they're valid. And that is incredibly important. And then finally, some kind of a provision so that if we later decide or discover that for some reason our threshold is inappropriate, that we can either have escalating penalties so that we can have sort of a prevent people to titrate doses, even if it doesn't work. So I'm just going to go back to SGF 1000. Near as we can tell, didn't do anything. There's people in jail for that. So just because it doesn't work isn't good enough. If people think it works, we probably need to have some restrictions on their use. With that, I'm going to hand over for some details of what we have actually done. I'm going to hand over the clicker to Dr. Tobin. Right there.
This is my favorite slide, courtesy of my wife, Vicky, who encouraged me to purchase it when it became available. You can see the gentlemen are getting ready to race. This is the early 1800s, and they are happily, one gentleman has a bottle that he's administering something to the horse, and the other gentleman over to the, more to the right, in the blue coat, has a bottle in his hand. Everybody is happily medicating a horse, and nobody is in the least concerned. But that's 200 years ago. And as Clara pointed out, 100 years ago, we started. One of the things that is very clear is drug testing, equine drug testing, racetrack testing is the longest established, it's the most sensitive, and it's the most broadly based testing of any routine drug testing on Earth. And that includes testing of us humans. We're testing our horses much more sensitively, much more broadly, and we've been testing them for at least from approaching 100 years. And that's where I work at the Equine Center, and I've been privileged to be there. Since 1994, we actually, I'm trying to remember who was the president of the HBPA in 1994, his name will come up, but we ran a international workshop on equine drug testing. And I'll never forget it. I called to Iowa, to a gentleman who was the chief of drug testing up here in Iowa, and I said, I'm running a international seminar on thresholds in therapeutic medications. He declined to come. I won't come if you're using the word thresholds. So I changed the title of the seminar, of the 2-day seminar, to testing for therapeutic medications, and he came. And we also brought in our Canadian colleagues, and at that point, our Canadian colleagues had limited sensitivity. They would test, they would cut testing off equivalent to 24, 48, 72 hours, which was a concept that was not widely accepted worldwide, but we put together a workshop and published it, and that was the start of the simply instructing chemists when to stop testing for substances. Now, the dose of a substance that you give to a human or to a horse can vary 100,000-fold. When you give metformin to a human, you are giving 3 grams of metformin to a human. 3 grams contains a number of molecules that is roughly equivalent to the number of stars, approximately equivalent stars in the known universe. It's a very large number. It's 10 followed by septillion, 10 followed by about 21 zeros. That's the order at a high-end dose. If you're giving elephant juice to a horse, you're giving it 100,000 times less concentration, and you're producing pharmacology. So so for some drugs, you have to have an enormous amount of the number of the molecules right there banging on the receptors to get the effect. For other drugs, highly potent ones, highly difficult to detect, the number is much smaller to produce the effect. So every threshold is unique to the medication, the no effect threshold. And the other thing, of course, that is unique to each medication is how it distributes in the, first of all, how it's handled by humans. Metformin and gabapentin are not metabolized. So when you go to the bathroom, when you take your 3 grams of metformin orally, if you're taking a high dose, and by the way, you're taking it in 3 split doses because you're metabolizing it rapidly. So every 8 hours, you put some more into your body. And every 8 hours, when you go to the bathroom, that dose goes unchanged into the water in the toilet and goes out into the human environment and wastewater. And if you're doing that on the racetrack, you're very close to a racehorse, and that's where that problem comes from. The dose is high, the number of molecules is large, they're not metabolized, and when it gets into the environment, it's stable in the environment. And the other point is it's an orally effective drug, so the horse picks it up and it shows up in the urine. The second thing is that when we set these thresholds, the plasma threshold is the most reliable. When you have a drug in plasma, it's there at a relatively narrow concentration because you're controlling the dose and the administration. So it's within a certain range. When it gets into the urine, the actual concentration in the urine can be highly variable depending on whether the urine is concentrated or not, but much more importantly, whether the urine is acidic or alkaline. And racehorses have a tendency to produce acidic urines post-race, whereas alkaline drugs, which are the ones that get into the central nervous system, will trap an acidic urine, and you'll have very high concentrations in the urine. And off from memory, I believe one of the metformins that was called by HISA, they did a blood and a urine, and there was a 1,000-fold difference in the concentration. It was a 1,000-fold more concentration in the urine than in the blood. So you set your thresholds in blood. And the last point is that if an animal has been exposed to simply a trace transfer, I generally recommend that the person consider hair testing the horse. That will give you an idea of the concentration. And since you can go over time, it will give you an estimate of the time at which the exposure occurred. Hopefully, it will be negative, and hopefully, if it does show up, it will be at a low concentration in hair. So those are important regulatory guidelines. As Clara pointed out, when we started in the 90s, I was working on the local anesthetics. We had worked out a good method to measure the pharmacological effect. So basically, I figured out the dose, the minimum dose, put it into the abaxial sesamoid block that would produce no effect. So I said, this is the smallest dose. This is the biggest dose you can give to a horse, produce no effect. Let's see what the concentrations in the urine are. And that's 30 years ago. So we were doing urine testing, and we produced cutoffs for the various local anesthetics, and we were working on that and continued to work on that. Tutane brought out his paper about 2 years later after I published a review, and he used the word irrelevant. And I like that word very much, because if I say something is irrelevant, you have to argue that it's relevant, and it puts the onus on you, on the person who is challenging you to present the evidence why it's relevant. I like the term, and also it's published. It's an extremely mathematical paper, so nobody understands it. So you say it's irrelevant, and you throw the mathematical paper to them, and it's a challenge. It's a negotiating strategy. The current goal that I've had, and I've been working on for a number of years, is when I see an opportunity, I will assemble the data and I will propose an irrelevant plasma concentration, and I will publish it in a scientific journal and say, here is and I propose it as an interim regulatory threshold or no effect threshold, because I'm not a regulator. I just say, this is what the science says, and I put the challenge out to them in the scientific journals to say yes or no on the science. One of the interesting ones, of course, is Aminorex. Aminorex is a metabolite of levamisole and showed up post-levamisole. First of all, Aminorex is a small molecule. It's related to amphetamine. It's a stimulant. It was used in human medicine at one point for its stimulant activities, and it produced adverse responses and was discontinued. And then suddenly it was showing up in racehorses I believe, first somewhere in Europe, and then in Ohio and in Canada. And then it was linked to levamisole. So people stopped administering. First of all, levamisole was declared a regulated substance because its metabolite was related to amphetamine. And the Aminorex identifications didn't stop completely. And Dr. Felder was working on a sequence. Oh, thank you. Okay. Clara has put the presentation together, and she knows the slides better than I do. Thank you, Clara. Levamisole is no longer available as an FDA approved for horses, but is commonly used off-label. but it began to show up not in association with levamisole administration. And we had some colleagues in Europe who looked at some some sport horses, and they were finding Aminorix in the urines with no indications whatsoever where it was coming from. And they pointed to the possibility that it came from a plant. And the next step was conducted by our research. We fed the yellow rocket, which is a plant that appears in Kentucky pastures in the spring, and it's very obvious. We fed that to horses, and bingo, there was Aminorix in the urine. So you could have these small amphetamine-related molecules showing up in horse urine based on what is in the pasture. This was a class, we looked then at the data, and at this point, what we have is the data that was reported by the racing labs saying that we found Aminorix in the concentrations, and we set the threshold just above what they were finding and said that this is a cutoff, and below this, the probability is that it's environmental and is of no regulatory significance. And we published that in 2019. About 2009, 2010, there were a couple of pemmeline identifications in English racing. Pemmeline is a central nervous system stimulant. It was introduced into human medicine in the 90s. It was found to be probably a little earlier than the 90s. In the 90s, it was found to be associated with severe cases of liver toxicity. So it was, as far as its availability for medical purposes in the United States and in most countries, it's not currently available. It's structurally related to Aminorix, and it showed up in a couple of horses in English racing, this time in association with levamisole. And I sent an expert opinion saying that basically pemmeline is so closely related to Aminorix and levamisole that the likelihood is that this is a metabolite of levamisole, and the British Horse Racing Association accepted that. At that point, the best scientific analysis was that pemmeline was a downstream metabolite of levamisole. We had a case in Canada, and I was discussing it I was actually getting ready to testify, and my colleagues in Europe reached out to me, and they said that basically they made it very clear that in Europe, they routinely see pemmeline at low concentrations in a horse urine. They don't know where it comes from, and they don't call it. They believe it's environmental and possibly plant related. And one of the things that I didn't get sorted out was whether or not the urines, what the pH of the urines was, because that would be the first question I would ask, on the assumption that they were trapping in acidic urines, and that's why they were seeing them. And at about the same time, if there's anybody here from Indiana, you remember in Indiana racing, there were communications coming in from the drug testing lab for the Indiana Racing Commission, advising horsemen to avoid the use of levamisole because they were associated with pemmelines. And these were not being called. They were coming as verbal communications to the horsemen from the commissions. And I called out to the laboratory, and it was discussed, and basically the whole thing went away. But there was a low level of background noise of pemmelines in Indiana racing. We have the communications in South African, German, both French, German, and South African and South American samples, pemmeline has reported in. So it seems like, basically, pemmeline is a naturally occurring substance like Aminorix in horse urine, and we looked at the scientific literature and we calculated a no effect threshold of 2 nanograms per mil. And as we speak, that is, and I've got my fingers crossed, is submitted for publication and is under review. And it's actually a very interesting situation where you have a central nervous system stimulant that was used in human medicine, and that has been showing up in post-race samples in Europe and around the world at very low concentrations. Methamphetamine, am I doing methamphetamine?
Yep, you're good.
Yeah, okay. Methamphetamine is another classic situation. This is the before they had thin layer chromatography, before they had ELISA testing, what they were doing was they would take the urine sample and they would form methamphetamine crystals, and the chemist would look at them and say, ah, yes, that's methamphetamine. And that was the way it was being detected. Now we can detect it at picogram concentrations in plasma, and we have it showing up in very small concentrations. It's a widely available street drug, human recreational substance, and the blood levels in average overdoses average at 100 to 1,000 nanograms per ml. If a person is using it as a recreational substance, the concentrations that they're using, the doses are large, the concentrations are high, and the format in which they're getting it will not be a nice a nice pill or a capsule. It'll be fairly loose substance. It's routinely detected in blood samples at less than a nanogram per ml in plasma serum. One of the interesting things and the complicating factor is that if the methamphetamine is transferred from the fingers of a human to the mouth of the horse, you have a high concentration in the mouth of the horse. And then if you're taking a blood sample from the jugular vein, the concentrations in the mouth and the concentrations in the jugular vein are going to be much higher than the systemic concentrations in the body. In other words, you're getting an atypically high blood concentration if you're using a jugular blood sample, which is a complicating factor on the interpretation of blood concentrations of methamphetamine. We have worked on, this work was done by our colleague, Dr. Heather Knitsch in California. And she also showed that there was if she actually did the experiments where she had an individual put gloves on and rubbed the methamphetamine on the mouth of the horse and looked at the range of concentrations that she got in the jugular blood. And some of them were particularly high, depending, I suppose, on the cooperativeness of the horse and the random effects. You can get a particularly high concentration, one as high as 84 nanograms per ml, and from the jugular, I believe, and also from direct administration, and there were no obvious stimulation or cardiac effects. Using the scientific literature as a guide and reviewing the facts of many of the cases of methamphetamine identifications, we proposed a no effect threshold of 1 nanogram per ml for the jugular blood plasma concentrations of methamphetamine. We assembled the data on this, submitted it for publication, and it was published in 2024. So we have out there in the scientific literature a clear presentation of what I've just told you. And Dr. Knitsch was very kind that she allowed me to replot some of her data, and some of the data from her paper is included in, we call it a case report and review. So we review the scientific literature, and Dr. Knitsch was very helpful in putting that forward. The summary of the published screening limits we have at the moment. For metformin, we have a proposed screening limit of 5 nanograms per ml in blood, which is much higher than many of the concentrations which are less than a nanogram, in other words, picograms that have been reported. That's published, and we, about 2 or 3 years ago, we proposed a screening limit for 5 for gabapentin in blood. Gabapentin is just like metformin. The human dose is high. It's in the order of 2 to 3 grams. It's not metabolized. It's excreted unchanged in the urine, picked up by horses. So it's a classic environmental substance. We looked at the literature. We estimated 5, and we submitted that actually to the Ohio authorities. The Ohio Racing Commission was calling it a quite significant sequence of gabapentins. And it turned out that Rick Sams had submitted a proposal His came in at 8, just a fraction over ours. And I believe that one was adopted by the Ohio, well, I know it was adopted by the Ohio State Racing Commission and put into place about I think about 3-4 years ago. Methamphetamine, we have proposed that a proposed screening limit. We have it here listed at 15. We have a no effect threshold of 1.5 in jugular blood. 20-hydroxyicodisone. This one comes out of Australia. Basically, what happened was we had a chemist in Australia reported these identifications. It's related structurally to the anabolic steroids, so it created some concern. But in harness racing in Sydney, they basically went out to the farms where the horses were coming from. They gathered some plants and they identified a hydroxyicodisone in the plants. And they included they basically cut it off at about 2 nanograms per mil, says we're not going to pursue these. And I basically reviewed the cases and put it out there in the scientific literature. Fentanyl was quite interesting. I was approached by chemists and a racing commission who were seeing fentanyls that are transferring from recreational users of fentanyl to horses, and presumably we have the same jugular blood effect that Dr. Knitsch showed in the blood. And I looked at the data points and I did some calculations and I proposed a no effect threshold, a relevant plasma concentration of 50. And I understand that I have seen, and I can't find it, but at one point I saw some evidence that perhaps a slightly lower concentration had been introduced by the HISA authorities. Benzylecgonine, we had a situation in Pennsylvania where Pennsylvania called a plasma concentration of benzylecgonine. Benzylecgonine has been regulated in urine, in humans and horses for quite a long time at 100 nanograms per ml of benzylecgonine in urine. Benzylecgonine is the major metabolite of cocaine. It's excreted at extremely high concentrations in urine compared with the concentrations in plasma, so it's readily detectable. And I went back and I dug through our data, and based on the data I had, I put together a draft opinion that I sent to Todd Mosteller, and I suggested 1 nanograms per ml as a plasma cutoff for benzylecgonine that would be equivalent to the 100 in urine that's been long in place. And I understand that's been accepted. I've already told you the pemoline story, 2 nanograms per ml. The mepivacaine story is 64 nanograms per ml. When we gave the highest no effect dose in the abaxial sesamoid block into a horse, the peak concentration of the metabolite in the urine, and what we see is mepivacaine that has been added, a hydroxyl group has been put on it, and then you put a sugar group on the hydroxyl group. So this very water soluble molecule is excreted in the urine, and the chemist spits off the glucuronide, and he gets the 3-hydroxy metabolite in the urine, and we put that in. We have 64 nanograms per ml as a cutoff. That was published quite a long time ago. Methamphetamine we've discussed. Synephrine was very interesting. It turned up in Australia quite a number of years ago, and the same people that did the hydroxyicodisone put in a cutoff in Australia. It turns out that in South African racing, synephrine is commonly seen, and they have a 50 nanogram cutoff in urine, and it's also present in teff hay. And for that matter, it's present in our own blood system, in our platelets. It's a very small molecule. It's out there widely. So I adapted the South African cutoff of 50 nanograms per ml and put that in the urine. Put that in, not in the urine, in the literature, published it, and that's been out there for a number of years. Tramadol, I hate to say this, I've been sitting on a paper for quite a while. Tramadol is a substance that is widely used in humans, But to be active, it has to be metabolized to O-desmethyl tramadol. So it's a prodrug, and it's metabolized to the active form. And in the horse, that metabolism occurs just like in humans, but the horse glucuronidase it very rapidly, excretes it in the urine. So basically, tramadol, as near as I can tell, goes through a horse and never hits a significant plasma concentration of an effective form of the drug, but you see plenty of it in the urine. Tramadol is less potent than morphine, less pharmacologically active, and we have a cutoff for morphines of 30 to 50 are conservative ones, and less conservative ones run up to 100 or 120. So I have proposed that anything below 50 nanograms per ml of tramadol as the metabolite in urine should not be considered of any regulatory significance. And the recent one, HISA, called on a Kentucky trainer, was actually, I think it was about, what, 2 nanograms per mil in urine. It was an extremely small concentration. And when you compare the fact that that concentration of the metabolite in urine is probably 1,000-fold less in blood, there's absolutely no possibility of a pharmacological effect. We've been publishing these. I've been very lucky that my old colleague, Dr. Andreas Lehner, is an expert at getting things. I can sit down, write papers, conceive them, and I enjoy doing it. But pushing them out the door is something that is not my favorite thing to do. And Andreas kicks them out. And we have a group of colleagues now working together very closely. Kimberly Brewer does a lot of the literature searching for us. She's a veterinarian in Florida. She's got a master's degree in toxicology. I have another colleague who is a Venezuelan out of South America who actually works in Dubai. And I put him on all these papers because he reviews them from the point of view of the South American community and from the Middle Eastern community. George Malin works with us and does significant analytical work for us and cooperates. My old student at Louisiana State University, Dr. Levent Dericalou. Andreas is at Michigan State University, and there's myself at the University of Kentucky, and Dr. Clara Feger across the road, and we're just working away quietly on these. And we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, I've got a dozen papers either published, submitted for publication, or close to final review, setting up these no effect thresholds, putting them out there in the scientific literature and saying, hey, folks, below this, there's good scientific evidence that there's no pharmacological effect whatsoever.
Thank you, Dr. Tobin. One of the points that I want to make sure and make is that if you're like me, you have people approach you and say, I don't know what the HBPA does for me. Remember, and obviously everyone in this room knows what the HBPA does, but this is something that you can point out. All of this research is sponsored in part or in full by you guys, by the donations that are sent in by the HBPA affiliates and national. So just point out that where we're making a difference in these peer-reviewed published literature, when that makes a difference to our regulators, it's because of you guys. And so, you know, keep the money coming first. And then, and then second of all, this is what you're getting for your money. Dr. Holland?
Thank you, Dr. Finger. Thank you, Dr. Tobin, as well. So one thing that I've been on a couple of these cases recently, which is kind of really fun to watch, sitting on one of their committees and then doing a case to defend people. But one thing that I've been arguing in some of these cases is we assume that the trainer is fully responsible for the animal from the beginning of the time it gets to the track to the time it goes to the gate until the time it gets to the test barn. Well, that's not the case anymore. You have ship installs, you have situations where you've got trailers dragging them in, you've got TCO2 areas, And in any of those cases, if we're going to go to very low trace amounts of medication to the lower limit of detection, you have the potential for a potential problem. So it's important to get an irrelevant threshold or a no effect threshold as you go. The other reason I bring this up is that racetracks are kind of really interested in the fact that in the morning, they see the horse in the home stall and they think their vets see it and then it just goes right over and then it races. They forget that sometimes the trainers will blow them out in the morning just to get them cool, not being crazy in their stalls, get them back. Some do, some don't. The banning in, you might even have home stalls in situations like Ron had, but at the same time, he was vanning over from other facilities as well, 3 different racetracks and 3 different facilities. So the home stall is not always the home stall for the horse. Receiving barns, TCO2 barn is an area that many of the racetracks are now starting to look into, and they may only clean those at the end of the day. So you have multiple horses that go through there for 10 races, and you're hoping that there's nothing in there, but you don't know. Okay. Paddock area, starting gate, test barn, and the pony horse people. We all have the potential for touching their mouth and messing with them. And as an ex-racing official, we also had the ability to tie tongue ties on. In one case, I said, hey, look, let's get the recent feed from this year's Derby. If you think we're all wearing gloves, putting these tongue ties on, let's go to the race 6. And the tongue tie fell off and you can see them tying it. And the reason we don't like to wear gloves is when you're wrapping that thing under their lip and pulling it back around on their tongue, if you get the glove stuck on it, goes snap and the horse wants to kill you. So we tend to not wear a lot of gloves there. Okay. Makes sense? All right. Contact points. So in your home stall, you have grooms, trainers, persons that set the feed, persons, the track pony will come over in the morning and help you get a horse working. You got the van drivers moving the horses back and forth. You have security personnel. You have horses that were in the previous stall. You have dogs and cats. There was a Gabby Penton where somebody was administering it to their dog in Europe. And then all of a sudden they were peeing around the stalls and the horse tripped positive, but it wasn't in any of the horses, humans, it was a dog. Vet certificates, we're taking those a lot more due to infectious diseases. And my background is infectious diseases from the Gluck Center. And so I look at all these things as potential sources, just as I would to help you with an infectious disease. The thing is, it wouldn't be an issue if the testing wasn't so sensitive that would get into these non-irrelevant systems. And so we're working really hard with the papers to try to avoid that, get peer review, let HISA and others, because a lot of times they don't even know all the information, and get them to understand what's going on out here. All right, at the gate in the receiving barn, once you go from there, you have stable attendants, racing officials, grooms, LASIX vet, HISA impact vet, inspection vet, dogs, cats, track farriers, identifiers, valets, vet jockey, pony horse track personnel, and the assistant starter. Every one of those people have the potential to touching your horse by the time you get there. The end result after the race is you have outriders, other people bringing them back, test barn assistants, test barn buckets. Every situation is not your home stall. So at the time, if you really look at it, you're looking at 20 to 30 potential impacts that could influence your horse that you hadn't really thought much about. Now, because we're lucky in that we don't have that much of a problem, it can become an issue. So just be careful there. What that means is if you go into the test barn and somebody's been drinking out of your bucket with water, you might want to dump the bucket and let them refill it again. And it's very common when horses are walking in the test barn, we say, go to bucket 3. And then all of a sudden the groom stops them at bucket 3 because the horse stops, sees a bucket, wants to drink, and doesn't want to walk by it because they've just run a great race. They're down in the test barn because they've won or taken third or in the top 3 or a random sample. So they're breathing pretty hard and they want to drink. This shows you the metformin positives from the beginning of 2023 all the way to the 2024. And what I want you to see is before HISA occurred, we were seeing metformins, and then after HISA occurred, we've seen metformins. So what we're really learning is that this one is probably truly an environmental transfer. If it was something where somebody would say, okay, they get positives at the first part of metformin, everybody's going to stop using it as a trainer and a veterinarian, and yet we're still seeing them, that leads more credibility that it is probably environmental from a contact source. We'll go through the rest of it, but anyway, the fines are pretty awful. They're 2 years. The legal expenses are pretty high. I think that it's hard for the trainers right now. So that's part of the reason why we have worked so hard to get down to a no effect threshold level to try to help avoid that for the industry, in my opinion. When we worked with Mr. Heddle at the Racing Commission in Kentucky, he was my head steward. And the thing we learned was if we were consistent, everybody played a level playing field. If we became inconsistent, we were all over the map. It actually hurt the whole industry. It didn't just hurt the trainers, meaning each one of these chemical identifications, people think we're cheating when in actuality, we're really not. Okay. So that's why we're looking at it so hard. I'm just going to skip through some of these to get on over here. Just to let you know, the plasma concentrations in a human and a horse would be up to 500,000 to 100 million picograms. They're calling these all the way out down to 25 picograms, 40 picograms in horses. So you're not having any effect with that level with a metformin. Okay. As part of the investigation, environmental contamination risks continue. We've swabbed horses and stalls that have been for yearling sales at a racetrack in Kentucky that sells a lot of horses. That's pretty obvious, Claire.
Rock on.
12 of 12 samples had dexamethasone and acepromazine in them just in the stall by the time you put your new horse in. So one of those swabs was high enough that would have tripped the tests for you all as a racing individual. All right, so that's obvious which barn. I like that. I don't know what racetrack that is.
Hit play.
All right, so this is Ron Moquette's section.
No, this is actually still you.
All right. This is cleaning the area up, but this is a stall area that we wanted to show how you would go about cleaning everything and checking. If you look at that individual stall, they have that material on the bottom to try to reduce the amount of hay and stuff you'd lose and pack in. The problem is you can't adequately clean it all the way out. You're never going to be able to get all that out of there. And so what they did was they took individual sterile samples, went around the stall and tested it. And sure enough, all of them were either low-level Dex or acepromazine, just from the stall.
All of them had both
Yeah,
Dex and Ace.
right.
That stall should be subject to a $25,000 fine and 2 years penalty of no compete.
Yeah,
If they-
agreed.
If they treated the racetracks like they treat the trainers.
Absolutely. To Ron's point, that's part of the reason why we have to explain this to people, because there are things that are out of your control as a trainer, like the stall. They assign it to you. You clean it the best you can, but sometimes you're still going to have a problem. And this is what this data is showing. And I want to thank the HBPA as well, because a lot of this work I don't think would have gotten done if it were not for you all wanting it being done. Okay. And it shows that each thing gets evidence, taste, and labeled just like we would do at the test barn. So that's how that works. This information is available for the trainers at individuals so that they know how to kind of discuss it with their legal counsel if they need it. All right. So based on the findings of dexamethasone at high substance environmental transfer, the fact that 20 to 30 individual contacts could occur, and of that, it's the number 3 drug that's used in the world to treat humans, your odds of getting near an environmental transfer are getting higher and higher with metformin. Metformin is commonly prescribed, and I give a lot of tracks a lot of credit. They saw there weren't enough bathrooms because they were worried about it as well, so they put porta potties everywhere. The problem with the porta potties is, how do you wash your hands? Right? Okay. So metformin is found in several water sources. This is a study that was done because we wanted to see what your individual water sources were coming out of your spigots. And the USDA did some testing. And if what's really kind of interesting is metformin, caffeine, codeine, many of these medications, tramadol, at low levels are coming out of your water sources because they can't get it out of the treatment water plant areas. The tracks are not going to be named in this kind of study, but for you to know, we've tested in Indiana, Kentucky, California, New Jersey, and Florida and Maryland. And we're starting to build a database for this to also say this could be additive, meaning if you came into contact with a metformin individual, but you're also getting low levels in your water, could it be an additive effect to get you over your threshold level and trip a test at a racing situation? The argument that you'll hear from the racing authorities when you see this kind of data is, how come all the horses aren't showing it? Well, it depends. When you take a horse to a new receiving barn, what's the first thing they do? They've traveled 3 hours, so they're going to drink more water than they've ever drank right from a new area, even though you try to hold off the water from them because they're sniffing and licking and doing everything in the new stall. So your potential goes way up at that type of a situation. And the metformin one. And I think it's important to know that all the samples we're doing, we're seeing low levels in the water. So I'm going to move it on over to Ron, because he's got a really good set of slides that we're going to bring up on how he cleans his stall. Do you want me to start it on that one first?
Yeah, you go ahead and do
You're
that.
gonna click through several slides to get there.
So
All right.
first off, the majority of what these highly intellectual people to my right said, I didn't understand. I'm a horse trainer, and I wake up every morning early. I go to work, and I try to do the best, just like the majority of the people you know that carry the license, including yourselves. The problem is I find that we're often in a defensive posture. I promise you that we did not give our horse meth. We did not hire someone knowing that they might have come in contact with meth, but we would be blamed regardless, the same as if we give a full dose of meth this right before we hung the bridle. And the problem that I'm seeing with this is confidence. The confidence of our sport has went down. The confidence of whether or not someone is actually guilty of attempting to gain an advantage or of being careless or reckless with their animal. All of that has gone away, and that's affected the overall product. It affects my business, and it affects how many people want to do the job that I'm doing. I didn't wake up every morning for 30 years and go to the barn and think that I'm willing to risk my career over a $5,000 maiden climbing race or even a grade 1. And the fact that we have to defend ourselves on that status is kind of hard for me to comprehend. We do a lot of things. I represent horsemen on the HACA advisory committee, and my whole position of there is to kind of do what I'm doing right here, is to inject common sense and practicality to what the people outside the stalls are saying. When they come up with a rule or they come up with a test or whatever I'm saying, you know, I try to apply it to a horseman's ideology and practicality. So I was recently in November, I got notified the dreaded HIWU letter that stated that I'd been found to have an adverse finding in a horse of mine's graded stakes race test post-race. And I did what everyone does, is I immediately wanted to throw up because I knew that I hadn't given it, and I knew that I was going to be burdened with proving it to save my reputation and to possibly save my livelihood. So everything that was going to happen that day immediately went behind trying to figure out, how do I explain that I didn't do what they said? And luckily for me, Keeneland, the Kentucky Horse Race Commission had started putting cameras in the stalls or around the stall area. And the first thing I did was call and say, does anyone have the cameras? Does anyone, how do I defend myself with this? You know, I need video, because you walking into somebody that doesn't know you or know your integrity or know your, you know, who you are really, and saying I didn't do something, they're going to go to the science. They're going to say, well, he seems like a nice guy, but he messed up. And luckily for me, in my situation, I was able to, I think I'm the first one to ever be able to defend myself with a video. And luckily for, in this case, for the regulation red tape that they constantly shove down our throats, we had turned in 4 weeks earlier, 5 weeks before the horse in question tested positive. We had turned in on a HISA report where we had gelded the horse in that stall, and that it says right there on that horse's HISA log that that horse received a generic, say that word again,
Epivocaine.
generic that 60 cc's whenever we were at each testicle when we were doing a standing castration.
And it's because the other one was back ordered. So
So-
that's why he had to use the generic, because the primary one was back ordered.
So when they're looking at this, they see findings, which I've learned recently, you're not supposed to use the word positive, but findings, they found this there. Can't argue with that. It was in there. Now, did I attempt to gain an advantage, or was I reckless in performing my duties as a horseman, licensed as a trainer? And I couldn't see that I was in either case. So I went to work, and me armed with ADHD and an annoying personality, I started calling, and I started asking and finally, luckily, Dr. Stuart Brown had the entire week leading up to that race where we tested positive, in which 3 other horses shipped out of that barn since the castration, had real-time footage, showed the horse in question that was turned in receiving the,
Epivocaine.
and it also showed us cleaning the stall.
That's right.
Dennis, can you cue up that last slide? It's
So
got his
show that-
video. It's not that stall, but it shows the
So-
procedure that he used.
So we have a standard protocol based on me having enough friends that's gotten contamination, that when a horse leaves a stall, we don't save straw. We throw it away, and we completely disinfect everything. And luckily, we had this being done to this stall 3 separate occasions. And the video that I'm showing you is a video that is something that is standard practice in most barns. We're not anything special, but we do this. So whenever I was to walk up there and armed with actual evidence, video of what I told them from the start, it was harder for them to automatically just discredit what I say as some cheating horse trainer. Everything I said was true, and I could back it up. The problem was then is they doing their job to try to, to provide integrity. They've decided that it wasn't good enough that they can prove that I didn't give it because they could see everything. But now I didn't do a good enough job providing a sterile environment.
This is an important point to Ron's thing too. They'll tell you it's not going to matter that they have the chemical identification to it, but it's circumstances that can also be mitigating that can be helpful. So keep doing your hunting, because if you had listened at the front end, the letter basically says it doesn't matter.
Yeah.
Correct?
Yeah. So here you'll see the standard procedure, and most people in here that was as confused by the first 3 panelists will understand this part. We do this. The problem that we're running into is as we're trying to explain to the people that are in charge to set levels to where you're not catching and accusing things that have no effect to racing, we're rapidly losing confidence among our consumers and among the participants in our industry that we're getting it right. And Dr. Daniels is on the committee with me, and he understands it's tireless work. You don't make any money for it, but you're there screaming out loud. And sometimes we're screaming down a hallway full of a lot of people that don't necessarily believe or like us. And then sometimes, we make an effect. Some of the things that come out of this, even though it cost me a great deal of money that I didn't have earmarked for this kind of thing, was I believe there's been 4 people use my case as a precedent for theirs. It showed that if you stand up and you're sure what you did what's right and you can prove it, you should fight it. The other thing is now we're able to get some financial help from the other side. We're the only thing I know that can be charged by a government group and then not be provided any help financially to prove your innocence. And until recently, thanks to the committee, we're able to now, if you were to, unfortunately get a bad test or whatever, the first thing is don't go spending money unless you have to. If you don't have it, then there will be a good attorney provided for you. Actually, it's probably going to be the same attorney that I had to pay money for. But whenever all of this is over, I think our jobs is to use these people beside us with their experience and their integrity to get it right. We, as a group that are make money off racing, and how you perform is how you get paid. We definitely want to make sure that no one has an advantage. We want clean racing. We want integrity to be the main thing that causes the results. And that's one of the things that's been allowed or, to be pushed to people that wanted to get HISA in, is that trainers don't want change. Trainers don't like people involved, and that we're okay with someone that we're in the race with cheating. We'll defend someone that's cheating. And that couldn't be further from the truth. We want a level playing field, but we don't want to have to be in a posture of defending ourselves for something we know we didn't do. As far as the changes goes, I've written before that in 2006, we won our first grade 1, was lucky enough with a horse named Seek Gold. And one of the things that they used with the jockey club and the proponents of HISA was that horsemen had a long time to get it right and evolve. And that's why we had to step in. And you guys don't like change. To which I've asked for several different people and finally had to come up with it on my own. Since 2006, in 2006 at Churchill Downs, Tim Glashaw and Alex and Rick Hiles can all tell you, you could run a racehorse in a grade 1 with Lasix adjunct, Winstraw, Enamine, Butte, Ketofen, L-arginine, and if nobody was looking, a milkshake. So you could legally run with all of that in your system in a grade 1 without a pre-race jog inspection and with very little veterinarian involvement. So I would argue we've done a lot of changes regarding medication reform. And I would say that the ones that are affected should have a seat at the table, no matter what. You can't have a lot of big words used that have no effect on what's actually you're wanting to do, which is to replace the confidence in our sport and preserve the integrity. If it doesn't work, or if it's putting the wrong people in jeopardy of losing their livelihood, then it needs to be brought back to center, brought back to what we want, which is a level playing field, and not to feel like we're in danger of our turning the barrel of having to provide a defense for our careers.
To that point, Ron did some really good things, right? Just taking a video how you clean your stalls. You never need to use it, but have it for background. If you have signs up that say don't pee in your stalls, take a picture of that. Just little things that can kind of help you mitigate some of this stuff. I call it standards of care. And it helps you. Never have to use it, but if you need it, you need it. And that helped a lot.
Yeah, I mean, I would tell everyone, and one of the things that the Arkansas HPBA is doing, and I believe Kentucky's looking at, we're gonna hang signs in every barn.
Right.
Those signs are your first line of defense. And if we're testing as sensitive as we are, while we're getting testing brought up to what it should be, then you should have these signs up in Spanish and English, letting people know that there's sensitive testing and it's not okay to urinate in the stalls. It's not okay to take your Red Bull in there with you. It's not okay to put your coffee cup in the feed tub. And in like a case that was just sent to me, a lot of people send me stuff to look at for them. A guy in California was having a hay company deliver their hay. One guy has a monster drink on top of the hay. It spills all the way down the hay, and they go ahead and put it in a barn. That guy doesn't understand the sensitivity of testing we're dealing with, but he doesn't realize he's responsible. And the person that is going to be accused of cheating has no idea what he's vulnerable for. So we're trying to get the message out. I think that's the best thing you can do is make sure you tell everyone, wash your hands. If you're on medication, I don't know the rules. I'm hearing that you can ask privately if they want to give you information about any prescriptions they're on that may give you a bad test, then you have the right to ask. Am I correct in that? I believe so. I know that there's rules about, privacy and medication, but
HEPA is a federal law as well for
So-
privacy and medication. So
They
we have to
don't have
remember.
to answer you.
Yeah, they
Yeah,
don't have
they-
to answer. you.
so, but
Right.
that's the thing is we are responsible, whether they choose to give us the accurate answers or not, we're responsible. So the more you know, the better you are. And if, I hate to say this, but if someone looks like they might be on metformin for blood pressure, I'm going to have to try to find someone that may not be. I can't afford to defend myself or something like that. And it's changing everything. It's changing the way we do things. And I believe that with the effect of their education and the common sense approach to wanting to make sure that level effect testing is in line, it may be our only shot at straightening the ship.
Oh.
And we need to thank HPBA for making sure these fine people have the funds to do what they need to do. And you need to keep fighting, no matter what, keep fighting, because it does affect you probably more than anything that's going on today. The work that they're doing has the biggest effect on the outcome of our sport.
I want to take one last moment in front of this group to comment that among our research initiatives is a water testing study. And we have the proposal Eric has that with a cover letter that all of the affiliates should have received. But as part of that, we have already tested racetracks in 5 or 6 different states. We're collecting water from a spigot at every racetrack, or trying to get every racetrack and every training center to develop a risk model for what kind of water sources. And for example, proximity to the Ohio River, or the Ohio River being the source of water for a lot of racetracks, or the Mississippi or tributaries, with the idea that we develop a risk model for positive tests associated with pharmaceuticals in the water. And we have done a pilot study, again, looking at about 5 tracks, and the findings of pharmaceuticals in the water pretty much reflects all of the other research that's been conducted by the United States Geological Survey. And we've teamed up with the United States Geological Survey. So they're actually going to defray most of the cost of this study. So what I'm asking from you is training centers in your state and as well as racetracks to get permission to collect water and then to raise or donate. The cost is $950 per site, which is a huge discount because the U.S. Geological Survey is providing most of the funding. So I'm going to request that everybody could do that in their location because to develop a risk model, we need everybody involved. We need everybody to contribute. We need every location where horses race off of to be included. So I'm going to ask that you do that, that you carefully read the proposal that's going to be distributed to you by Eric and see what it is we're trying to accomplish. And again, we've already discovered that metformin of all things is among things that are at the top of the list for it's not just in water elsewhere, it's in the water coming out of the spigot, going into your horse's water bucket in at least one location. So we're trying to develop a risk model, and the best way to do that is to get everybody involved. And then the only other comment on that is the actual specific results are going to be anonymized, meaning if you happen to be the dirtiest racetrack, your name's not going to be on it, right? It's not going to say this track is really bad. The data are going to be distributed to the racetrack management that gave us permission and the scientists. And if they choose to say we had one of the cleanest sites, that's up to you. It's up to them. But that the actual data are going to be confidential.
Well, thank you, guys. Let's give them a round of hands before we open up for questions. So before we take questions, let me first just thank Dr. Tobin for reminding me why I didn't get into vet school, organic chemistry. Unbelievable. I really appreciate this group, and I think you guys know and can now understand why there's such a, such a sounding board, a reactionary call, if you want to say it that way, for me when I need some help or advice. But one of the things I want to encourage that's been touched on, that term no effect threshold, irrelevant concentration. Most everybody in this room hopefully is now aware of our, being the National HBPA, push to engage the FTC on establishing a rule that HISA/HIWU has to abide by their own act and prove that there is relevance in what concentration a medication has to affect a horse, right? So we are trying to force them or show their hand and say, you need to enforce your own act and prove, or I should say, make HIWU prove that the medication in the horse's system has an effect. So we have initiated a rulemaking petition. We're up over 330 comments so far in the FTC. You guys have been getting emails. If you haven't, seek me out. We will try to get you emailed, and you email everyone you can. Our goal is 1,000 comments to the FTC to understand how badly this is needed. So where did this come from? We touched on it with the tramadol. Rusty Arnold, who had the 2.9 nanogram positive, he came to Jenny Reese and myself, and he's always been kind of quiet. He works, or he trains for some members that are certainly supportive of HISA, but he's fed up. Rusty wrote an excellent piece that we distributed a few months back, which initiated this conversation to put forth to the FTC. We also initiated, I say we, I'm going to have to include the Ingram Group, who is our lobby team in DC, who's been side by side with us in this fight. We initiated a one-on-one conversation with Representative Andy Barr, Republican from Kentucky, 6th District, my congressman, but he's the congressman for a lot of people who have pushed this initiative. We were able to get those two together. We had Representative Barr's staff and himself read the op-ed. He seemed sympathetic. He understood. And by the time they left that conversation, Eric Bunning, one of the Ingram Group team members, they said, gosh, Congressman Bars, he's understands this. He can support this. Even though he's one of the people that pushed HISA, he understood that having a medication test and it not have an effect on a horse doesn't make sense for anybody to suffer a violation. So what happens? Andy Barr goes to the CEO of now HISA, explains what he's heard, talks about it, even expresses that, this makes sense. I should do this. Her words were, nothing of those, the substances that they are pushing to have a no effect on should ever be in a horse, period. No level, nothing. Now you've heard the science, and we've been on this soapbox before HISA, so I don't want to say that we haven't, but we need no effect thresholds because the trainer responsibility rule, again, it's outfinished reality. We have science that can test well below the deck of having a relevance. And so we need this established. We need your help. I'm not going to say that this is going to make a change, but everybody in DC, the FTC included, and all of these authority members and these standing committee members, they need to hear Ron. They need to hear Dr. Daniels. They need to hear the people on the Horsemen's Advisory Group, but they need to hear from you. We have got to be proactive and pushing back, but pushing the narrative that we don't want cheaters in the game, but we need to have established no effect thresholds. Look, metformin everybody's talking about it. The reality is, let's say somebody was using it, right? They've tried to use it for performance enhancing. Nobody knows what the performance enhancement would be, but the reality is everything has an effective line. It is a widely legal medication. Maybe it has a use down the road for equine medicine. So why would it be any different than bute? Why would it be any different than Banamine? Why is it a banned substance when it's not even on the WADA code as being recognized? Why does the EPA not recognize picogram levels in human drinking water? No effect. It's common sense. And too many people have lost that common sense. So I'm going to keep pushing for it. I may be the only one, but I doubt it. So let's open it up for questions. Or not.
One of the things I was going to say while we're waiting is use the HISA Horsemen's Advisory Committee, sort of like your state representative.
Yeah.
If you have a question or you have a concern that, don't come yell at us because we didn't make the rules. We're literally going to walk up and represent you and say, a friend of mine or a colleague is having trouble with this. Let us represent you. Or when I go off of the board and somebody else comes on the committee, be sure to reach out to them. Don't let your voice not be heard because you don't feel like that you want to talk to, the people in charge. Talk to someone that is equal to you, does usually what you do. Talk to Dr. Daniels, talk to me, there's trainers and owners all over, and make them or let them be your voice, and don't ever have anything that you want to say not be said. The only way we're going to get this right is to have input from everybody. And the fact of the matter is the people with the greatest knowledge base are the ones that's sitting out there, not the ones making the rules.
Judge Walmsley?
Yes, I have two questions. One, Ron, is to you, and it's indirectly related to the subject today. But I want to ask you if you and our president's presence on the advisory group, have y'all caused some opinions to be changed from time to time on specific medication type issues?
Yes, you can look at, I'm taking credit for it for us, but you can look at stuff like the methamphetamine being lifted to 4 times greater than it ever was. That's should be directly from our input. There's a long list of things that we've accomplished while we're on there. And I can tell you that was not for people like Dr. Daniels and the rest of the people that work on that thing. You're left to explain yourself and the reasons why certain rules should not be enforced or applied to someone that has no idea, except what the information they've gathered is that the majority of the people that do our business is less than integrity driven. So I'm very proud of a lot of the stuff. There's a lot we got to do. When I leave here today, I'm driving back to Kentucky. And as soon as I check on my horses, I'm going to be on a subcommittee that's talking about something that's very important to us. And I feel like that if I wasn't there, then I pray to God someone like me is, that shows enough interest and has their ear to at least make them hear our concerns.
So you believe it's very important for us to have a presence on
We-
that advisory group?
I wholeheartedly believe, and you need, the louder the better. And I'll say this, I've almost been appreciated at the fact that I argue. Whenever I stand, I'll listen to the people, and then whenever it's my turn to say something, I'll say, well, that's just absolute shit. And they'll be like,
Question.
okay, great. Okay.
Question for Dr. Finger and the other medically qualified members of the panel. You've told us about studies that you've done, that work that you've done, particularly on the no effect threshold. Do the HIWU HISA people have any or medical evidence that they present that conflicts with yours?
No,
So they,
all we get is 2 things. One is 1 picogram has 1 picogram worth of effect. So if when races are won or lost by 1/10 of a second, you don't know that picogram didn't have an effect. Well, you saw the presentation. I know it didn't have an effect. That's absurd. But that is one of the things that's said. And the other thing that is said is what Ms. Lazarus told Andy Barr, which is these things have no business in a horse at any level, just like the sharks off the coast of Florida.
do they and does she ignore the possibility that it could be an environmental contamination?
Well, I mean, Mary Scalay legendarily for years said there's basically no such thing. If environmental contamination was a thing, then we'd be getting it in all of the horses all of the time. And that just doesn't jive with the actual science of how pharmacology works. So, they don't understand that. Even in cases that were well documented environmental contamination, there hasn't been all horses all the time. The scopolamine positives, this is pre-HISA, but the scopolamine positives in California that Justify was caught up in, there were like 6 positives and hundreds of horses got that same hay. So there are a number of other factors that go into it. And even when we have well-documented cases of contamination, they're not all positive. One of the studies that we've done, again, sponsored by and funded by the HBPA and affiliates, we did a dexamethasone study where we gave a pony dexamethasone, collected the urine, put 100 milliliters of her urine on hay and offered it to 6 horses that lived in a stall, and we pulled blood every 4 hours. All of the horses tested positive, although most of them below the threshold. There was a threshold then. They tested positive once. 1 horse tested positive twice, meaning negative, positive, negative, positive over the course of the 24 hours. So point being, wherever your race is in relation to whenever that exposure occurred, if you look at the total number of time points, when we had clear contamination. And over the course of 24 hours, they all had some positive for dexamethasone after that happened. The actual risk, is pretty low because they were tested every 4 hours. And most of the time they tested negative. So there's a lot of other factors that go into it, and it's very naive to say that just because it's in the environment, they should all test positive all of the time. When I reviewed the positives for HIWU, the 0.49% from the adverse analytical findings, they clearly almost all, essentially everything, if you get rid of the controlled medications, everything else fit the description of an environmental contaminant extremely easily, stable in the environment, readily available, common human pharmaceuticals. So you could just about say they were all, it's quite possible they're all environmental contaminants. There's actually not one instance of cheating that was been identified.
Thanks, Doc. Let's move on to the next question here.
My name is Howie Chavers, and I'll keep this kind of short, but I have more of a statement than a question. I want to thank Dr. Finger and Dr. Tobin. The funding for this deal is amazing. I was accused of having a metabolite in a sample, 58 picograms, and they did all the research, all the study, and found out, yes, this metabolite could have came from this drug, but it also comes from vitamin B3, niacin, and it also can come from a Coreodalis weed. All that research, all the genius things that came into that. So I didn't lose my license. I was looking at a suspension for over a year, minimum 12 months, even though I've had 36 years. I've never had a suspension in my life. They don't care. And so the funding has to keep up for these people. And I just want to say thank you so much from the bottom of my heart that I can still pay my 3 kids into college. Thank you.
Has RMTC made any recommendations, and has ARCI adopted any of these thresholds?
So I brought the same presentation because, as I commented, this initiative is co-sponsored by the United States Trotting Association, and they are still under ARCI. So I brought this exact same presentation to, at least my part of it, to the ARCI meeting in Columbus last, whatever it was, March. So at least it's being considered. My problem with the RMTC Scientific Committee is it's a little bit biased because it is almost exclusively the lab directors. And so they like calling positives because that makes them feel good. It makes them feel like they're doing their job. So it's an inherent conflict of interest for that. And so I don't expect a good result from the RMTC. Maybe I'm just biased. Who knows?
I would just suggest to Eric that we at least try to get them to adopt these thresholds.
I do know that some members of the RMTC have asked for the articles when they finish. They'll ask for the peer-reviewed articles and send them. So I think they're teaching themselves as you go. And I've always felt that this research is really important as well, because at times we might not know the answer, and it's good to say we don't know the answer. So RMTC, HISA, other people will know. If the scientists can't find the answers, then you might need to do other kinds of research. So sometimes the answer is we don't know, but I do know that our MTC members have reached out and asked for the articles when they're done.
Doc, can you explain, or do you know why when HIWU sends out that dreaded notice, they don't put any concentration of the positive that was found until you ask for a beef sample? Dr. Finger, can you?
So, obviously banned substances, they say are a violation at any level, so they don't have to provide it. I think in 100% of cases where, at least where we get an attorney involved to ask, we've gotten that. Once we get the lab packet from them, we can calculate that, but their position is for banned substances, there is no threshold and they do not have to provide that. So that's what the standard answer has been.
So one thing I wanted to ask before we leave. How many jurisdictions out there have cameras on the backside? Say, I'm astounded that more doesn't, just to protect the horsemen. I don't understand why there's not more funding for it. I don't know if that's something that the HPBA has to step up and offer to help, because at the end of the day, we're helping horsemen, and sometimes that could be the only level of defense. We've proven that if it's just our word of saying that we didn't do it, that it's not gonna bear any difference. So I would say that with my case, without the video evidence, I am just another cheater doing time. So I would like for everyone to at least consider talking to the racetrack owners and or the HPBA and saying, look, as this testing goes on down the road, we at least need to be sure to protect our horsemen.
What a great panel. Thank you, guys. Well, great. We've gone over a little bit, but that is certainly normal for this panel. It's something we could sit here and talk all day long. But we're going to